turn it on. So I just wanted to say hello first. I'm Jessica Gray. I'm one of the MCSTAP consultants, and I'll explain all that. And I'm here with you for the next hour to talk about Bupe, and then hopefully have a follow-up in 2 weeks that as many of you can join as are able, where I want to hear from you what questions you have, and then we can dig into sort of more of a cases and didactic than didactic. And so it's also super helpful to know who's on, what your experience level is, or anything you want to share. So please feel free to drop it in the chat. And I am going to get started by sharing my screen. Awesome. Emily, can you see this?
Yes.
Perfect. Okay. Awesome. So welcome everybody. This is our sort of semi-annual Bupe 101 in the era of fentanyl. And so trying to keep everyone updated for folks who are new prescribers, hopefully tidbits for folks who are prescribing, and we'll go from there. So you can see my disclosure here. I'm part of MCSTAP. Clearly you know about us because you're on the call and joining. So thank you so much. Here's how to reach us. We love helping folks with these questions. So no question is too small or too big. Please use us. Right. So our goal is MCSTAP is to support clinicians in increasing their capacity to and comfort with treating and supporting patients with substance use disorders and chronic pain. So you can call any day, Monday through Friday. I'll get one of our physicians who can help walk you through your question. Here's what we do. We have coaching. We have real-time checkup. We have, follow-up support. We have sort of all of the above that I'm not going to get into. And then for one-time consults, and if you felt like it was really helpful and you'd actually like to work with someone one-on-one for a few months, we are very happy to do that too, as well as work with trainees. So please do be in touch if it feels helpful. There are a ton of us, again, each taking a half day throughout the work week. And we are really here because we love teaching and we love supporting others in this work. So you can get credit for discounts as part of your risk management, DEA licensure credit, and CME credit. So feel free to use that, and we will dive in. So we have 3 big objectives today. One is to become familiar with the nuts and bolts of buprenorphine prescribing. We'll review some induction strategies and their evidence, and then explore the impact of illicitly manufactured fentanyl on Bupe dosing and some of the newer Bupe formulations. Again, I have a packed agenda here, so my goal is to sort of use this as a didactic. Please write down your questions in the chat. We will collect them. I'll collect them, after, and then tailor our second meeting to really thinking about what specific questions you have. So I will start with a case. A patient comes in and says, "Doc, I heard about buprenorphine films from a friend, and could you prescribe them to me?" So more information. He's a 56-year-old retired laborer, shares he's been taking non-prescribed oxycodone from a friend for years to manage his chronic pain because he wasn't able to find someone to prescribe the dose he needs. He's spending hundreds of dollars a week on his pills, he says, and really prefers OxyContin 30 milligrams, taking it 3 times a day when he can find it to manage his pain. And so, these are some of the questions that you probably would have, and I want to go through them throughout the next couple of slides, right? What criteria does he meet for an opioid use disorder? What other history is relevant? Is he a good candidate? What do I need to know about prescribing? And what else should I be thinking about? So first, in terms of how to make the diagnosis of an opioid use disorder. So the diagnosis is really done based on history, right? So this is true for any substance use disorder. We use the DSM-5 criteria. Broadly, substance use disorder is a maladaptive pattern of substance use leading to clinically significant impairment or distress, manifested by 2 or more of the following 11 criteria occurring at any time in the same 12-month period. And you'll notice that the asterisks around withdrawal intolerance, those by themselves cannot give someone a diagnosis of a substance use disorder because they just imply dependence, which can be from other medications or medications that you don't necessarily have a loss of control over. So, some of the questions to ask are around hazardous use. Has it impacted your relationships or conflicts with others? Has it led to a failed meeting of responsibilities? Have you been using more than you intended to? Have you tried to stop but haven't been able to? You're spending more time using or craving the substance, that you're using it despite causing harm, and given up activities. And so if we think about this case with what little information I gave you, here's someone who's found his own supply of buprenorphine. I mean, sorry, of pain pills. He said he's taking sort of a high dose, but the same dose when he can every day. And, the next questions would be around really asking him around how it's impacted his life, sort of going through the questions 1 through 9 to really get a sense of if he meets criteria for a use disorder. Certainly has risky use. So this is how I would sort of approach the DSM. And so why was he buying pills off the street, right? I think just to level set, it is pretty impossible to get pain care at this point in time. And there's incredible stigma around asking for pain medication as well as access to buprenorphine. So, for many people, they're doing their own self-treatment because it's easier than engaging in the healthcare system. So, as I mentioned, right, the most important thing is to get a history and then use that obviously to build a patient-centered plan. So we talked about confirming the diagnosis. Part of that is really understanding his current and past use pattern and any exposures that may put him at risk. So also thinking about complications from use. Has he had ever, been unintentionally over-medicated? Is he sniffing it? Is he injecting it? Is he chewing it? Is he swallowing it like a pill? And he shares that he prefers that he never has injected, he's never sniffed it. Then when he can't find the 30s of oxy, he'll take whatever short-acting medication he can find. He said he doesn't feel out of control and that his tolerance has gone up, but he's able to stop once he feels okay in terms of his pain. He doesn't know that he's had any withdrawal symptoms that he's aware of, but he has spent all of his savings in order to manage his chronic pain. Doesn't have an overdose or over-sedation history that you elicit, and he notes he's retired, lives with his partner, and he likes to fish. So again, you go through and sort of assess this and really think about, okay, does he have a use disorder, right? And you can argue that he certainly, has an increase, but then steadied his dose of his, again, non-prescribed. So I think this is one where you could make the argument, yes, he at least has risky use. He's sort of going outside of the health system, and he's really a perfect candidate for buprenorphine. And so that is one of the questions: has he ever tried it? And which he hasn't. And so who is a good candidate for buprenorphine? This is someone, who has a current or past diagnosis of an opioid use disorder, that they are open to taking the medication, keeping it safe, that they haven't had any significant adverse effects of the medication in the past, and we'll talk more about precipitated withdrawal as a sort of exception to that, that they're willing to work with your team to initiate and continue treatment. And really, that they have a shared goal around the medication. And so it could be a reducing or abstaining from non-prescribed opioid use. Note that it doesn't have to be abstaining, right? That it could be decreasing the harms of ongoing non-prescribed use or reducing the risk of return to a non-prescribed opioid use. So then, the question that comes up is, well, he's got chronic pain. That's what he's treating. Can I treat his pain with buprenorphine naloxone? And so this is just a general reminder of the formulations that we have available. So the sublingual formulation, Subutex, Suboxone, those brand named are approved for addiction, but not pain treatment, right? So they are FDA approved for addiction, but they can be used off-label to treat pain. Whereas the parenteral and transdermal formulations of buprenorphine, which are in the microgram dosing versus the milligrams of the sublingual formulations, are approved for pain and cannot be used to treat addiction off-label. So that is a very important point to take away, that you can use for the FDA approved for addiction. You can certainly treat pain with them and not the reverse. And then the other thing to know is that the presence of chronic pain is not a barrier to successful opioid OUD treatment. People can get benefit from the analgesic properties of buprenorphine or methadone. Okay, so what do you need to know before prescribing buprenorphine potentially to this patient who comes in asking for it and has a pretty significant opioid dependence? So first are the major features of buprenorphine. Many of you may be familiar with this graph. I think it's just helpful to reorient ourselves, right? The buprenorphine is a long-acting partial agonist, so it has a half-life of 24 to 36 hours. It is an partial agonist at the mu receptor, meaning that it only halfway, you could think of it, activates the receptor, unlike a full agonist. So you actually have the benefit of not having the respiratory suppression when used as prescribed. It has a very high affinity for the mu receptor, and that is great in reducing accidental overdose and reducing mortality, because once it's on those receptors, it binds and does not let other opioids on. However, if other opioids are on when you take it for the first time, it displaces those other opioids, which can lead to precipitated withdrawal, a miserable state that I'll talk about a little bit later. And then the other property that's helpful to know about with buprenorphine is that it really, once it gets on the receptors, it has a slow time of dissociation, so it stays on for a long time. And all of those properties we take advantage of as we think about the benefits of buprenorphine. So what do traditional buprenorphine inductions look like, right? Here's a guy who comes in, I'm ready to get on it. So this has, been, I think, over 10, 15 years of how we get people on buprenorphine traditionally, which is that you need to have a gap between the full agonist and the partial agonist so that you don't cause someone to go into precipitated withdrawal. So you need to be in mild to moderate withdrawal to be able to take the initial dose. In this case, essentially, you wait till you have at least 3 objective symptoms of withdrawal. Start with a half of an 8 milligram film. As long as you're feeling okay, you would then repeat that dose, 45 minutes to an hour later. As long as that person's feeling okay, you could be done, or you could need to, if they, start to feel worse again, then you would give another dose. In sort of the pre-fentanyl era, up to 16 milligrams that first day. The next day, then you would take it again, just sort of the whole dose in the morning, or split the dose in 2. A lot of this has gone out the window in the era of fentanyl, but this is still sort of the traditional, best studied induction. In terms of where this can take place, people are doing it all the time at home. There's good evidence that it is safe. It's often patient-centered, it's more efficient, less sort of a havoc on your clinic to need to have someone stay, in their office all day. And I would say the most important thing is to really listen to your patient. If this is someone who knows exactly how their body needs to get on the medicine, then they probably have a lot more experience than you. And so I just want to highlight just a thought on toxicology testing. You'll notice that in the DSM-5, there was no requirement for toxicology testing to make a diagnosis of an opioid use disorder. And so while it may be beneficial, especially in that first day, to confirm, what's in their system, you do not need to have a toxicology test result to be able to, or even a test, but a result to prescribe and start someone on medication. The goal is to really start people the same day. And so in terms of frequency, that's another question we get of how frequently should we be doing toxicology testing? The answer is there's no federal requirements. There is American Society of Addiction Medicine has a consensus document which provides sort of a general standard of care recommendations that we can talk about next time if that would be helpful. But just know that it really is an evolving space, and that it used to be sort of like very heavy-handed in terms of testing guiding management. And I hope that sort of people are moving away from that, in that there are significant harms to testing and really only specific benefits. So it may help confirm the patient is taking a prescribed medication. It may help recognize potential interactions with other medications. And then it also may help identify sort of what is in the drug supply, whether exposures or adulterants, if the toxicology test you choose, is specifically looking for those. Okay, so what are the steps for then actually prescribing buprenorphine? You have someone in front of you who wants it, who would benefit from it. So just a little plug that on our MCSTAP website, we do have a document that walks you through all this. So if you're someone who prefers that visual, this is just what the document looks like. But it's similar to any other controlled substance, right? So you would check the prescription drug monitoring program. The requirement is you or a representative with every single prescription you send. You then pick a formulation of buprenorphine and a length of prescription that's usually based on, what formulation the insurance covers. Usually you just, order buprenorphine naloxone. These are two examples sort of a 7-day supply of 2 foams a day, or of the 8-2 versus the 4-1, the 8 being the buprenorphine product, and then the naloxone -2 being the naloxone component, just in the most commonly prescribed formulation. And then you would e-prescribe buprenorphine. So it is a DEA Schedule 3, and so requires electronic prescribing. For folks who are new to this, generally like a week of medication at first is very appropriate for follow-up, unless there's other sort of conditions or situations. Buprenorphine and buprenorphine naloxone do come in multiple doses and formulations, and so happy to go over that later if that would be helpful. And then finally, please do not forget to co-prescribe naloxone and think about all the harm reduction pieces that I'll go over. So I want to highlight a couple of legislative updates over the last few years that I think are important to know as you're prescribing. So it used to be that we had an X waiver. You had to get a separate sort of DEA approval to prescribe buprenorphine. As of the end of 2022, that is no longer needed. So any prescriber of controlled substances can prescribe buprenorphine, right? So what are the conditions for that? The conditions are that you either have graduated from residency, where you got the 8 hours of training, or have done an addiction fellowship, or have completed 8 hours of opioid training on renewal of your next DEA. And so this would be one of those 8 hours, for example. And I think the other important legislative update to keep in mind is that there was a loosening in COVID of initiation practices for buprenorphine and other medications, allowing us to actually start someone, same day via telehealth for this life-saving medication. And that has been extended through the end of this year. So I think important to know that you have to keep an eye on where that is going with federal law. But right now it is still very much you're able to do that. Okay, so in thinking about this patient, want to highlight some other things to think about around safety and harm reduction in part of your conversation, right? So sort of put out the universal precautions that everyone should be thinking about and talking about with an opioid use disorder. So, does the patient know how to use naloxone? Do their family members or someone that they are with know how to use naloxone in case of an unintentional overdose? And I break it out. I show them how to use it. Do they keep naloxone at home with their medications? Do they keep their medications safe, locked, out of reach of children? I also let people know that naloxone is perfectly safe on anyone from a baby to an elderly person. So it's the same dose, it's the same medication. You will not harm anyone if you are worried that they had an opioid overdose and you give them a squirt of naloxone into up their nose because they're not responding. The only time it would affect someone is if they're physically dependent on opioids. And so really important for folks with kids, babies, to let them know, in addition to keeping their medications safe, and that goes for all opioids, that it is safe and for an accidental ingestion on kids. And then finally, really letting people know about the illicit drug supply. And so what does that look like? Well, in Massachusetts, the best website to go for sort of real world data on what's going on with our drug supply is the Massachusetts Drug Supply Data Stream, or the MADS Street Update. And you guys can QR this and I'll give you guys slides. after. But what this really does is it's a great program at a Brandeis that is drug checking and figuring out the shifting sort of waves of toxins in our drug supply. So for example, in 2021, they highlighted for us that there were fentanyl analogs coming out into the community. So we were seeing fentanyl in cocaine, heroin, counterfeit pills, and they were actually able to sort of identify that that on the ground trend that we were seeing in terms of increase in overdose risk, and that helped us with really educating patients how to be safer. And it's an ongoing process. Then in xylazine, came to Massachusetts, and I think hopefully everyone knows that it is a veterinary tranquilizer. It's got alpha agonist properties. It is a brutal both in terms of the skin ulcers that it produces, but also just the sort of non-opioid withdrawal that's very difficult to treat and very uncomfortable. And so, in 2022 when it came out, about 1 out of 4 fentanyl tests that were done actually also contain xylazine, and then that increased to half of all drug samples contain xylazine in the first quarter of 2023, and in pockets of Massachusetts, it's nearly universal. And so this is really an important one to talk to patients about, and they're great sort of free public information that you can find online and handouts, patient handouts about how to think about this. We also see counterfeit benzos, so designer and synthetic benzos that aren't detected by standard assays. So again, if someone's saying that they're buying benzos and you don't see it, this could be one of the reasons. And then our stimulant supply is incredibly contaminated as well. We have methamphetamine in non-methamphetamine products. So, folks who are dependent on opioids or have an opioid use disorder may be exposed unintentionally to methamphetamine. And then levamisole in cocaine, which is a sort of another veterinary medication. So just to, there are a bunch of questions in the chat. Let me get to the chat. Oh gosh. Oh, hi everybody. If the patient has a legitimate pain problem and cannot get needed pain meds within the healthcare system, why does he have an opioid use disorder? He will probably not get adequate pain relief from Bup if he needed 10 milligram oxy TID. So this is a really great question, and I think wasn't planning on getting into it today, but you're absolutely right that sort of depending on how you assess this guy's level of risk, he could just meet criteria for opioid misuse, right? He is sort of taking it outside of the healthcare system, and actually for him it may be that the safest thing is for you to then put him on 30 TID of OxyContin, which is what he's prescribing, or other long-acting full agonist opioid. However, if that, I think it's very reasonable to because of that history to say, buprenorphine actually may be a medication that does help you with pain as well as sort of opioid misuse. And so it's perfectly appropriate, I think, to see if you can get him comfortable on buprenorphine. I think the fact that he is asking for it and he sees other people benefiting from it, means that he is sort of bought into the idea that it may be of value for him. And as we're thinking about sort of initiating people on long-acting opioids and high dose, I do think buprenorphine is a safer choice. And if you completed the 8 hours before 2023, would that count for the DEA? No, I think as long as you save that information that you've done that training, that should count. And I'm going to minimize again. Okay. So yeah, to wrap up, I think maybe that was just enough discussion to wrap up that case. And we can certainly talk about that case or one similar in our didactics next week or 2 weeks, if that's helpful. Okay, let's move on to case 2. Oh, sorry, let me actually finish him. I apologize because this was a real case. Actually the patient decided to do a traditional induction because we did actually test for his urine to see if he was exposed to fentanyl or not, and he wasn't, which is fascinating because you rarely see oxycodone these days anymore, or he has access to it, so I should say. So he had a pretty simple induction with sort of the traditional gap in the gap in his full agonist while waiting and then getting onto buprenorphine. He actually did end up feeling good on he initially did 4 milligrams 3 times a day to take advantage of the analgesic properties, and then ended up on I think 4 milligrams twice daily and then 8 milligrams at night. So again, it is a very strong buprenorphine is a very strong opioid, so there may be benefit for some patients, even if they're if you're worried that he should get full agonist. Okay. Case 2, so thinking about buprenorphine inductions. So this is a 38-year-old who's in your office for a new patient visit, was seen in the emergency room 2 weeks ago for overdose requiring naloxone. He had left the emergency room with sort of a 6-film kit of buprenorphine naloxone. Took it and then ended up sort of restarting fentanyl use again. But he's here to see you now, and you've heard about the substantial mortality benefit of MOUD, and so you decide to offer buprenorphine. And so in this case, you have someone actively using fentanyl. And so what are the steps in evaluation of this person? What's a traditional, you've already heard traditional induction. How does high potency fentanyl or high potency synthetic opioids or fentanyl impact the induction? And then think about sort of other pieces around safety and harm reduction. So again, you've heard this, right? What are the first steps in evaluation? The diagnosis is pretty clear here at this point. Right, but really, this is the time to really dive into understanding his use pattern and exposure, and as well as prior experience with buprenorphine. Right, so he, in this patient, right, it's really helpful to break down how often he's taking fentanyl, what his withdrawal is like. Has he tried to get on buprenorphine in the past? How did it go? How was it post-emergency room, or other experiences? And so in him, right, the question for anyone really is, has there been high potency synthetic opioid exposure, right? And how can it impact our buprenorphine inductions? And so what's in, sort of high level takeaways of fentanyl or other synthetic analogs are that they rapidly cross the blood-brain barrier. They have a rapid onset, much higher potency versus morphine, around 50 to 100 times. That's very variable with our illicitly manufactured fentanyl. Fentanyl is very highly lipophilic, and so you get this rapid fat sequestration for someone who's using it heavily and frequently. So different than like as a for a procedure that's medically prescribed. And interesting studies have really shown that with someone regularly using fentanyl, you actually see that there's a delayed renal clearance, and so we're seeing fentanyl sort of linger, and norfentanyl, the breakdown product, linger in people's urine for weeks. And I think the other and most important piece that you face with patients is that really there's an unpredictable withdrawal course in coming off fentanyl, which has been really challenging for everyone. And so what is the big fear in the room? It's really precipitated opioid withdrawal. And that in order to sort of standardize a definition of precipitated withdrawal, sort of the clinical definition is that it's the rapid onset of objective signs of an opioid withdrawal syndrome 30 to 60 minutes after initial administration of buprenorphine. And so I think the important point here is objective signs of withdrawal that occur sort of at the time when, for example, sublingual buprenorphine peaks, which is 30 to 60 minutes. And just listed some of the common opioid withdrawal symptoms that you might see there, such as pupillary dilation, piloerection, really extreme restlessness, vomiting, and diarrhea, and just really miserable. And it's a change in the clinical opioid withdrawal scale by more than 5 points. And why does that matter? So first of all, it's miserable, right? So it's miserable for patients to go to feel worse when you give them a medication that's supposed to make them feel better. It's incredibly stressful for medical teams to have to watch this. It usually leads the patient to just return right to other opioid use. People then are afraid to use buprenorphine in the future, and we only have 2 agonists available as first line for opioid use disorder. And it also contributes to real trauma around the experience. And the challenge is that there is sort of tremendous variability in how people sort of experience and think about precipitated withdrawal, and also important to keep a broad differential diagnosis. So in terms of the variability, I would just say that the sort of non-objective signs of opioid withdrawal that can come, right? So the anxiety can also be seen in other sort of in slower withdrawal periods, of more physiologic withdrawal than sort of the rapid withdrawal from putting a partial agonist too quickly on top of a full agonist, and sort of the acute abrupt sort of drop that you see. And so keeping the differential broad, just important to think about, could you be missing anything, right? Again, if you gave someone buprenorphine right in front of you, watched it happen, it's pretty clear. But if you didn't, and if they just described it in the past, right, it could actually be that they just didn't, they had a waiting period, but they didn't get enough buprenorphine in their system to actually sort of match the level of opioid dependence and tolerance that they had. And so you're seeing untreated natural withdrawal. It could be that there's other substances interfering, right? Are they coming off of benzos and therefore are anxious, restless, tremulous, right? And then are we missing another medical condition that makes them look like they have the most miserable, sort of GI flu of their life? So again, important to consider for these considerations. And so in all this, and given just the real challenge it's been to get on buprenorphine, this is just a great article from now a couple years ago, written by some folks with lived experience, really asking clinicians that, or telling clinicians that we really need new ways to initiate buprenorphine in the fentanyl era, and that sort of that traditional induction doesn't work anymore. And so what are the emerging strategies? I shared these, a couple months ago too. There is really what we just have our case studies and reports, and then clinical experience. There haven't been any head-to-head trials. So the sort of other ways to get on buprenorphine besides stopping the opioid and then giving comfort meds and waiting until someone's in withdrawal and giving the partial agonist include sort of modifying that to give a high dose induction or doing what we call low dose crossover. So I'll just go through those, excuse me, so you have a sense of it. So high dose buprenorphine induction, what's the concept? It's that instead of the traditional induction that I just described over sort of 1 to 3 days, you actually smush that into sort of a rapid escalation in hours. So rather than taking 4 milligrams and then waiting and taking another 4, maybe another 4 later, you're actually, once someone gets into sufficient withdrawal, you are just sort of slamming them with a high dose buprenorphine. So sort of 16 at once, another 16 milligrams an hour later. And the rationale behind it is really that you minimize sort of this period of under treatment and rapidly get the full benefit of the opioid agonist from buprenorphine, and also reduce someone's risk of overdose if they return to use in that process. Critically, in this case, you have to be in withdrawal, right? You can't just put, if someone's comfortable in their opioid, you can't just put, 1632 under their tongue. It will be incredibly painful. Again, really want to think about high doses. So target of getting to at least 24 milligrams in the first doses. There isn't a consensus on the clinical opioid withdrawal scale, sort of how much in withdrawal someone should be, or the timing or the doses. And sort of from sort of anecdotal clinical experience, really, you want to err on the side of being more aggressive with buprenorphine. You don't want to be timid here, and to use comfort meds. And so again, these are case examples, right? So we don't have great studies on this, but it's certainly being done. So there's some pre-hospital EMS administered high dose buprenorphine examples in literature. There's folks who've written up the naloxone self-administration and then rapid high dose buprenorphine initiation after that. It's been done in emergency department and sort of less it's been done sort of in post-incarceration, and then sort of less examples in the outpatient, but still an option. And then a really great website just for your resources, the California Bridge. So it's bridgetotreatment.org. They have wonderful, this is one example of a protocol, but they have wonderful examples of all types of buprenorphine protocols that are meant to be shared. So definitely check that out. And then the other question I sometimes get is, okay, what do you do after that first day? You know, they've gotten 1632, 64 milligrams of buprenorphine, 40 milligrams of buprenorphine that first day. They don't need to continue on that high dose. They actually, that's sort of to get them over the hump, and then they would go down to, you know, sort of more typical dose of 16 to 24 milligrams. Okay, so the other emerging strategy is the low-dose buprenorphine with opioid continuation. And what that means is that the patient continues their full agonist, right? So continues taking, whether it's pain pills, whether it's, you know, illicit fentanyl, whether you're in the hospital and doing it in a controlled way, they, you know, continue their full agonist, and then you inch on the buprenorphine over anywhere from 2 to 7 days in micro doses, right, in very low doses. So, you know, for the outpatient world, it's usually a 0.5 milligram or a quarter of a 2 milligram film, because that's what's available, you know, for prescribing. Inpatient, there's a lot more flexibility, as you can see here, because you can use IV, you can use buccal films, which are a lower microgram. You can use transdermal patches initially to get sort of people to those first doses. Again, the initial doses are typically less than 1 milligram, and there's a lot of case series looking at this in different settings, in inpatient, in outpatient. I would say that there's not been one sort of superior approach, and often there's a lot of adjusting to meet the needs of the patient in front of you with very close interval follow-up. The other question is, well, how can you do this in the outpatient? You know, are you really telling someone to just keep using fentanyl? And the answer is no, you can't. You know, it's very hard to say, I'm your doctor, right? Keep using fentanyl while you do this, but you know, the reality is it's not going to work unless they continue their opioid supply at the same level. So in an ideal world, they would go to a, you know, medically supervised withdrawal or treatment to get on buprenorphine, or you could potentially, you know, use a 72-hour rule to give full agonist to reduce their risk of overdose. And in the real world, sometimes that's not happened. So this might be sort of the best that you can do with a really careful, you know, shared decision-making and documentation of that plan. And so again, just to highlight that there are many different low-dose bup with opioid continuation protocols. You do not need to remember any of this, but here for resources in terms of thinking about the different ways that people have tried to get folks onto this medication. So to summarize, because I think it can just be a little bit head spinning, in terms of opioid induction options, we have sort of the traditional, or call it standard option that we talked about. We then have sort of a low dose option of requiring still a washout period from between the full agonist and the buprenorphine partial agonist. And then you have what I talked about, which is the high dose option. And so all of these are just variations of a sort of an induction where you have a period of withdrawal. They each sort of have a variable first dose of buprenorphine, you can see, and sort of variation in the initial first day of buprenorphine dosing, and recommend comfort medicines to help support people through it. And so those are all with the sort of non-continuation. And then there's the sort of different approach, which is, again, continuing the full agonist, inching the buprenorphine on so that it sneaks in based on its properties and slowly builds up in the system without causing precipitated withdrawal. So I just want to contrast that these are two different things. And what I think really confuses the process is when you don't pick one of those with a patient and then they get confused and they do something in the middle, which won't work. So again, sort of like there are two general strategies that you would have to decide on with your patients. And so what makes a buprenorphine induction successful? All these pieces and probably more, right? You need to really know what the patient preferences are. Do they want to stop? Have they lost access to their supply? And so this is the moment to be able to just, rapidly get them on buprenorphine. Will they be able to tolerate? Do they have comorbid pain, making that really challenging to tolerate? What's the timing, right? Are they willing to go to a higher level of care? Do they have supports at home? Were they just, kicked off their methadone clinic and so you are stuck? Right. So how much time do they have sort of to make this even happen, right? Are they going away in 3 days or, they have 2 weeks and they want to do this, comfortably? Where is it done? It's, I say, very helpful to have a place where you really need daily check-in and high touch for these patients. And so if you don't have that capability in your office, like there are bridge clinics now all over Massachusetts that can really help sort of stabilize your patient and then get them back to you on the medication. So again, it does not all are this complicated, but if they are, happy to help, happy to call us at MCSTAP 2 for ideas. And again, it doesn't need to be done in office, but certainly if someone wants it to be done in office, it's nice to, to have that available if your clinic can support it. Again, what are your clinic resources? Are you so short-staffed right now that this is not feasible, right? And so sort of knowing what you can do, a lot of these can be nursing follow-ups. And so hopefully that can sort of reduce the burden. And then again, lastly, think about what are the agonist properties of the sort of either medication or drug that the patient is taking, and think about how that could impact the buprenorphine induction. Okay, so that case who came to you who overdosed and had successfully gone on buprenorphine after that, and then had a return to use, came back to try it again. Had decided that they wanted to do a low-dose bup crossover after all of your counseling. Eventually was able to successfully get onto buprenorphine. And now you see them now. They've completed the home induction. They've been coming weekly for the last 2 months. They've been taking 8-2 milligrams of buprenorphine twice a day for a total of 16 milligrams. And you're getting toxicology testing, and it's actually, persistently showing fentanyl in it. So is this working? How do you optimize treatment and keep him safer? And so the first thing I will say is that this is a great study from 2016, old now, but important to remind us that it is expected that people have ongoing use during early treatment, right? So this is folks who are on methadone or buprenorphine versus zero treatment, and it takes months, even on treatment sometimes, for some people to really be able to extinguish their use. That's not true for everyone, but it is not, it's not failure if someone is ongoing use, but is able to, continue to take the medication. And so that's one piece to sort of set expectations on. I think the second is that we are under treating a lot of our opioid use disorder patients with opioid use disorder by keeping them on sort of lower doses. And 16 is now considered a lower dose of buprenorphine for folks who are actively using fentanyl heavily. And so this is a study that came out in 2023, which it showed that for folks who are on 24 milligrams in orange versus as a daily dose, total dose versus 16, they were more likely to remain in treatment. Just more evidence that that we're sort of underdosing. So this is a study actually that looked at serum levels of buprenorphine, and what we used to think was actually an effective serum level to sort of block-like ability of of Dilaudid or another medication when tested in the lab was around 1 nanogram per ml. It sort of went to 2. What we're finding actually with fentanyl is that people need actually a serum level potentially of 3 nanograms per ml in this study to really not be able to feel the full agonist when they use on top of it, right? So even if they inject on top of the buprenorphine, they don't feel it. They don't feel it at a sufficient blood level and don't get high. So not only does it stop overdose, but it also reduces the likability, which is more likely to reduce time to reduce ongoing use. So is it 3 nanograms per ml? There's another study that said maybe it's actually 5 nanograms per ml in terms of blood level, serum level, right? So there's another study that found that actually people at 5 nanograms per ml were most effective in protecting against fentanyl-induced respiratory suppression. And so there was a great commentary or the review by Grande and et al. Which, to summarize, right, really said that the current FDA guidance for buprenorphine dosing recommends a target dosage of 16 milligrams and a range from 4 to 24. But we now have decades of independent research to establish that individualization of doses of at least, up to 32 milligrams increases patient safety and retention in care, and that the strict dosing limits that they currently have, keeping people under 32 milligrams, actually leads to patient harm because of the contaminated drug supply of fentanyl. And so really it's a call to, to advocate for our ability to make our own decisions around diagnosis for our patients, right? So for this patient who, was doing okay on 16 milligrams, right? The first thing would actually be to go up on the buprenorphine, would be to understand, okay, what are you feeling? I'm taking it twice a day, but in the middle of the day, I feel like it stops working, or, I'm having cravings all day, right? Those are the questions to ask. And then the first thing would be to see if a higher dose would get them to a more therapeutic level, knowing that, again, we are shooting for a higher serum level to get the same effect with fentanyl. In time here. So what else is helpful to think about as you're thinking about taking care of folks with opioid use disorder, maybe on buprenorphine or not, in the outpatient setting? This is a paper that I was part of. I think it's a helpful sort of framework to think about of things you could potentially bring back to your practice. The first one that I mentioned at the very beginning, right, is that abstinence doesn't need to be the goal to have someone be in treatment, right? So it's good enough to have someone who wants to reduce their risk, who wants to prevent overdose, right? Who wants to, sort of reduce the amount they're using, maybe how chaotic it is, right? Those are totally appropriate treatment goals. And not everybody the goal doesn't have to be abstinence for them to get care with you. If we exclude everyone with the most severe disease from getting treatment, right, we're doing nothing but causing harm. And so those are the folks who actually we want to engage in care so that they can get primary and preventative services. And bringing sort of some of the harm reduction suggestions listed on the side will really into primary care settings, right? And primary opioid use treatment settings will allow people to actually be safer, to improve their engagement, but also to improve health outcomes. So important to think about. The next piece that I want to highlight here is this amazingly wonderful hotline. So you can take a picture of it. It's easy to find on the web. You can send and get stickers and business cards for Safe Spot. And this is a free helpline that your patient can call. And there's always someone on the line with lived experience who will sort of be their spotter, right? So if they're, we never want someone to use alone because there's no one then who could rescue them if they unintentionally overdose. And so the idea is if your patients, when you talk to them, are using alone, then, Narcan's naloxone's no good. So I'd offer them, well, have you heard of this number? It's totally anonymous. They take your demographics, their name and location specific. So it's not anonymous, but they don't keep it. But the idea is that they can then get, should you not be responding throughout the period that you're using while they're on the phone, they can get an ambulance to your where you're staying and rescue you. And they have rescued many people. And so I think this is, as you're thinking about harm reduction and really helping folks who are sort of using alone or be a little safer, this is a great resource. And so the last piece that I want to talk about is a little bit more about other formulations of buprenorphine. So these are long-acting injectables. And I'm curious, I can't see the chat, but curious sort of again if folks are using these, and again, happy to answer questions or think through cases with you guys at the next one on these medications too. So what are some of the benefits of long-acting buprenorphine? Well, they provide a higher and more consistent serum level than current sublingual dosing, which I mentioned before, maybe suboptimal for the fentanyl we're seeing. They're a potential option for folks who can't stabilize on the sublingual, whether they can't tolerate it, right? So some people just absolutely can't stand the flavor. Or have dry mouth, so the absorbability or absorption is decreased. The dose, they just can't get the right dose of sublingual, or they're just too unstable, right? They can't hold on to their medication, right? And so need something that really takes then away the need to have to remember to take something either once or multiple times a day. It is so for the most part, they're monthly. There is also weekly. In general, with all of them, it takes about 4 to 6 injections to reach steady state. So that's 4 to 6 weeks or 4 to 6 months, and that means that for folks who are sort of on the heavier side of using fentanyl, they are going to likely need sublingual supplementation in the first part of treatment in order to feel comfortable, and so that's been seen. In terms of the other thing you can see is, and we can talk more about this, but in terms of loading the dose, because you're not at steady state or getting to therapeutic dose in those first couple months, you may need some other loading doses, which we can talk about, and then right. So instead of sort of the traditional 2 of the sort of loading doses for Sublocade, for example, people may actually need to extend those higher doses. There is really interesting emerging use for the weekly medication in inductions and rapid starts that I'm happy to talk through. So we now have 2 options. So we have the Sublocade and the Brixadi as the second FDA-approved formulation that came out, was approved in 2023, and that's really where the flexibility came in. This is my attempt at putting these together so that you can sort of see the difference. So there's different dosing options. Here's weekly. Brixadi comes in 4 doses. Monthly comes in 3 doses. Sublocade comes in 2 doses. The weekly Brixadi is FDA approved in pregnancy. I'm happy to answer questions about that at another time too. They're all Schedule 3. The Brixadi doesn't need refrigeration, whereas the Sublocade does. And then in terms of initiation, again, the weekly is we're learning sort of has potentially more flexibility because of the sort of rate of rise of serum level versus the monthly. So in the weekly, the time to peak dose is listed as about 24 hours versus the monthly is rapid.
Are a couple questions in the chat. I don't know if you want to.
Yes, let me just, I have one last slide, I think, and then I'm happy to address them. So I think the last thing I'll just leave, again, for folks who are doing using those 2 formulations, really interesting sort of flexibilities that may be coming from Indivior in the near future. So the FDA is reviewing them right now in terms of the ability to use rapid sort of same day initiation with the Sublocade, or actually shortening the interval between the first 2 doses, again, to get someone onto peak and potentially changing the location of the injection. So more to come on that. I left you with a bunch of take-home thoughts, but I'm happy to summarize quickly and then chat. So right, getting a good history is all you need. Labs can come later. You shouldn't sort of avoid starting someone who, because of getting a toxicology test. Everyone can prescribe as long as you have a DEA and are doing 8 hours of training times 1. Really got to be careful with adulterants. We're learning more about how challenging that can be, and really important to educate your patients on that. Harm reduction should just be a part of all the care you give. Their inductions do get complicated, and so we're happy to provide resources and help at MCSTAP. And then again, there's like risks and benefits to each of these sort of off-label inductions to think about with your patients and document those discussions. We do expect, and we are seeing obviously that that maintenance doses of bup need to be higher in fentanyl. And then do not forget naloxone, and don't forget methadone as a really good option for folks who this medication isn't right for, as it's also excellent. So what I'm going to do now is I'm going to stop sharing. We will have a few minutes to chat now, and my hope is really that I can gather questions or cases so that we can then use our time in 2 weeks to be able to really dig in more. So let me find you guys again and look at the chat. Which froze. So can you guys see me?
Yes. Do you want me to read the questions for you?
Yeah, because my chat's frozen.
Not a
So,
problem. Phoebe asked a bit ago, has the Bridge Clinic attempted the high dose version? I know you said it has not been used much in outpatient settings. And we
yeah.
also have a
Oh,
question.
sorry.
Yep. Go ahead and answer that one. And I'll read the next one.
Oh, I didn't know if it was related.
Mm-mm.
So yes, we have, although very rarely. So I think in talking to folks, the the hardest part is really getting enough time um, away from full agonist to then be able to do the high dose. But we have had folks that we've done a high dose. We actually we're leaning more towards actually injectable inductions now, just because it we can get that on board and then also get the films on board. So I would say that it is not nearly as commonly used as others, but we absolutely have sort of, once someone's in withdrawal, really loaded them with buprenorphine.
We also have a question from Dr. Lennox. What do you consider the appropriate setting for initiating fentanyl withdrawal? Addiction clinic, bridge clinic, hospital-based outpatient venue only, question mark. If fentanyl use is expected in 50% of the drug supply, the option to initiate buprenorphine in a primary care office setting seems to be very limited. Is this an argument for talk setting as part of the initial steps and evaluation? What are your thoughts?
Yeah, it's a really awesome question. So I'm going to go backwards. Number one is ask your patient. Most patients know if they're being exposed to fentanyl or not. And so I think, the case that I gave was like sort of a rare case where he's actually, finding pills. But I think more often than not, the folks I see, they know they're getting fentanyl. If you're injecting anything, it has fentanyl in it. I would assume our rates are much higher. I mean, I think in Boston area, fentanyl is completely saturated. The illicit market. So it is so rare that we would only see heroin versus oxycodone are prescribed. So I do think it can be really valuable to get a toxicology test as part of an initial evaluation. And I would but I would assume I wouldn't wait to treat, and I would assume that it is fentanyl. In terms of where to do an induction, it really comes down to resources, I think, and the patient leading the way. If the patient feels comfortable saying, you know what, I can do this at home, I'm going to do it by myself, I've done this before, then you just go ahead and, and prescribe, and obviously, talk about precipitated withdrawal, but and see them back. But oftentimes our patients know how to do this. They have much more success than we do. So I'd say primary care can absolutely be a place to initiate someone on buprenorphine. I think what's hard is if you wanted to do it sort of in office, or if they were doing sort of a low dose crossover or something that required a high touch, right? It would depend on the resources you have, in the clinic, and also comfort and experience, right? So there are bridge clinics. I think someone asked about Berkshire County. I'll have to look it up, but there are, bridge clinics can do remote support too, right? MCSTAP can also, right, do remote support. So I think there are ways to thankfully get help and support within our state at this point. I do think it's easiest to do any of these inductions in the hospital or in a supervised opioid withdrawal setting, like a detox or acute treatment setting, just because you can sort of more aggressively treat. You see how they respond. You can add comfort meds sort of more aggressively if you need to, and for inpatient, you really control the full agonist supply, right? So you can put someone on an MS Condon bridge, you can put them on methadone while you're sort of doing a cross titration, and that's outside of the 72-hour rule. That's not legal as an outpatient. Okay, I think that's probably enough for that question. Is there trouble getting buprenorphine paid for through insurance if we use it for the off-label of chronic pain? Phoebe or others, any thoughts on that? I have not run into that, but I mostly treat like comorbid. So if anyone else wants to jump off and comment,
It's
please
been a
do.
while for it. This is Phoebe. It's been a while since I've done that as well. And I've had patients in the past who were already on it for chronic pain, and I don't remember getting having problems with it. I think it's, but yeah, I also can't say definitively what the status of that is.
Awesome. So I know that was a whirlwind, and we sort of learned a couple years ago that we couldn't do all of this in one setting. So the hope was just to sort of give you a potpourri overview, enough to get started if you need it, and then hopefully whet your appetite for thinking about buprenorphine more with us. And so I know we're at time, but if you either want to email Emily or call us at MCSTAP, or put it in the chat for the next minute or two if there's topics that you want us to dive further into in 2 weeks. Really happy to share slides. Again, I have cases that I will go through, but really like it when folks have questions that they want us to dive deeper in, that we can answer. So thank you guys so much for coming. And I realize that lunchtime is over for a lot of you. So enjoy the rest of your day, and yeah, let us know how we can answer more questions or bring a case or two. I'm happy to dig into. And then Emily's going to send out CME information. Awesome. And I'm going to try to see if there's other questions I can bring to next time. And thanks for those who commented with who they are. Nice to see you guys.